Hi, my name is Mollie Hutton. I'm one of the genetic counselors here at Roswell Park. I'm going to be talking today about risk assessment and genetic testing related to hereditary cancer risk. In doing such, I want to make sure that people have a good understanding of what the genetic counseling process looks like, as well as understanding the importance of genetic testing for patients as it relates to treatment and surgical planning. We'll talk about the move in paradigm to having genetic testing performed more often by the providers, and also touch on the difference between the different types of genetic testing being used in the clinical setting today. So first of all, genetic counselors, we are master's trained medical providers. We work on talking with patients and families about hereditary risk for different diseases. We do have national board certification. State level licensure exists in some states, but not all. And cancer genetics is a subspecialty. So in our basic training, we do cross into training that relates to prenatal, pediatric, adult onset genetics as well. Here at Roswell Park, we only facilitate genetic testing related to a hereditary risk for cancer. So genetic counseling is actually a process, and what genetic testing, or genetic counseling I should say rather, looks like is that in general, a new patient appointment can be up to 90 minutes long. And during that, we are collecting family history information and personal medical history information. This is kind of the first level of testing that would occur in identifying a potential hereditary risk. Once we have collected that information, it allows us to better try to identify whether there is a potential hereditary risk, what that might look like for the patient, and we will discuss with them the possible differentials, as well as what type of cancer risks and medical management options might be available to them and their family if this were to be confirmed. And then we also help facilitate the genetic testing process. I think the most important thing for people to always understand is that the majority of cancer is not hereditary. And so despite the fact that this is in the news all the time, it's on every other magazine of late, is that only 5 to 10% of cancers have a hereditary component to them. And so we in genetics only work with a very small subset of families affected by a cancer diagnosis. The majority of cancers remain to be sporadic occurrences. That being said, however, hereditary cancer risk does branch across multiple organ types. And in general, we would say that 5 to 10% of almost every tumor type potentially has a hereditary component to it. Generally, we are dealing primarily with solid tumor cancer genetics. However, the hematologic malignancies is a growing field. So the most important piece to what we do, like I mentioned, is the family history. And in getting a family history, there's a lot of details that are important to our assessment. And so we are always collecting a 3-generation pedigree. We need to go beyond getting information just on the patient's siblings or their parents. We need to reach out across aunts, uncles, cousins, as well as their grandparents. We need to differentiate whether the relative with cancer is a maternal versus a paternal relative, because we need to track the cancer risk down the same bloodline. And in getting the family history, it's really important that we try to document exactly what type of cancer the relative had, their approximate age of diagnosis, and really clarifying what those diagnoses are. It's very different for our assessment, potentially whether we are talking about a cervical cancer versus a uterine cancer versus an ovarian cancer. And so sometimes it takes asking a few more questions to really clarify that. And one of the most important things is to realize that family history is always changing. And so this needs to be updated on a very regular basis as new diagnoses may come up as time goes on. There's actually an ASCO guideline that exists indicating that medical oncologists should be updating family history on a regular basis to always allow for reassessment of potential hereditary risk in a family. It's also very important as somebody is collecting family history that we don't focus the questions to the disease site that the patient is sitting in. So, if the patient is at the urology clinic, we need to ask about more than just prostate cancer. It's really important to realize that with hereditary risk, we rarely are assessing for a singular disease, but rather we are assessing for a clustering of cancers within the family. And so when we see prostate cancer in a family, it could be associating with various other things, including breast or ovarian cancer. And the same with the GYN clinic. We can't focus just on the females in the family and the GYN-associated cancers. We need to ask for other things as well. And like we said, this needs to go beyond just asking about immediate family members. So one of the biggest questions that often comes up is how to identify what patients are appropriate for genetic evaluation. Like I said, the majority of cancer diagnoses do not need to have genetic testing. What we do know is when we identify a patient who is an appropriate candidate for genetic testing, the most appropriate person to test in that family is generally the people who've had a cancer diagnosis themselves. And we know this is not always possible. Those relatives may not be available or interested. But when possible, that is going to be your best and most informative way of doing genetic testing. If there is a mutation that exists in a family, most likely it's going to be identified in the relative who had a cancer diagnosis themselves. And that allows for more informative genetic testing than for the rest of the family. What are the red flags that would be suggestive of hereditary risk? These include, and often what we're assessing for is to say, have there been multiple people within a singular family and within the singular bloodline who've been diagnosed with cancer? Are we seeing the same types of cancer over and over within the family, or cancers that we know can be associated with each other? We are looking to say, how old were people when these diagnoses occurred? Cancer is an aging process, so it's not as unusual to see people diagnosed in their 60s and 70s. When we have individuals who've been diagnosed in their 30s and 40s, this is going to be much more suggestive of a hereditary risk. We are assessing for whether there's any rare types of cancer in a family. And so anytime we see ovarian cancer, pancreatic cancer, male breast cancer, these are all things that should certainly raise consideration of genetic testing for that family. And then we know ancestral background can be important as well, and this is most appropriate in relation to often breast and ovarian cancer diagnoses. We do know people of Ashkenazi Jewish ancestry are more likely to have a genetic cause for those types of cancer. And so, the NCCN does have guidelines that exist to help identify which patients are appropriate candidates for genetic testing. This also would suggest that they are likely to have insurance coverage for the genetic testing to be completed. And so we often are referencing those to help guide this assessment. There's also a very good article that was published several years ago through the American College of Medical Genetics, which is kind of laid out another form of guideline to help providers identify patients who are appropriate for genetic testing. And so this is just a snapshot from that article. What you can see here is the way they laid it out is to indicate that with a particular diagnosis, when there are these other features associated, this would be an appropriate consideration for genetic testing. And so for providers who are feeling a little overwhelmed at being able to identify appropriate patients, this is a good resource as well. So I have some people say, why do we need genetic testing? We already know they already had cancer. We need to just treat that diagnosis. And we would say, well, there's a lot of benefits and value to doing genetic testing. If we can get to people before they've had a diagnosis, that would be our most meaningful approach, which would be to say, can we have early detection? Can we identify the individuals and the families who have a higher risk and make sure they're being screened appropriately so that we either can try to prevent a diagnosis or we can help ensure that things are going to be caught at their earliest stage. When we know there's high risk, sometimes risk-reducing surgeries are something that may be considered. Treatment is being affected by genetic testing more than ever as well. There may be more tailored treatment options for somebody when we know the genetic profile of their tumor. And then finally, family risk. This goes much beyond just the patient themselves. This is something that is a family risk as well. So the big paradigm shift in genetic testing happened about 4 or 5 years ago in the sense that we moved very much away from doing single gene testing more towards what is now multi-gene panel testing. This shift occurred as more and more genes were being identified to be contributing to a hereditary risk for cancer, and as the technology became available to allow for panel testing to occur. And I think the most important piece to understand is that there's really not a one-size-fits-all test. There are a lot of things to be considered. Multigene testing is a very complex issue, and there's really no guidelines to help identify how to do this. And so even us in the genetics community have kind of struggled through helping to identify when do we identify how much testing each patient needs. It still needs to be individualized, and how best should we do that? You know, when we think about multi-gene testing, we have to think about, well, what genes are we testing for? You know, different laboratories approach this in different manners, but what we really have seen is there's been a breakdown between genes that are considered highly penetrant and carry significant risks for cancer in the presence of a mutation, versus the more moderately penetrant genes, where we would be saying, well, this mutation does indicate an increased risk for cancer, but not necessarily a significant risk for cancer, in which case maybe the medical management is not going to be as greatly affected or impacted. And so the question is, well, are those worth knowing about? The other thing being is that with each of the different genes we can evaluate for, we see different combinations of cancer risk. So rarely are there genes that are associated with risk just for breast cancer or just for colon cancer. And rarely are there genes that are associated with risk for every cancer, but rather we sit somewhere in the middle. And so with some of these multi-gene panel tests, they've been set up in a disease site fashion where we could say, well, we want to test for multiple genes, but we really want to focus just on the breast cancer genes or the colorectal cancer genes. And a lot of these genes are going to sit on multiple panels because of that overlap. You know, if you're dealing with the genes related to Lynch syndrome, where we can see risk for colon cancer and uterine cancer and prostate cancer, obviously those genes are going to exist on multiple panels. But again, one of the challenges in providing genetic testing to patients and their families is trying to identify what genes should we be testing for. And so this is just a quick overview of kind of how complex it really can be. This is a chart provided by Ambry Genetics, which is one of the clinical genetic testing laboratories. And what you're looking at here is that with each of the columns and the different colors are different panels that they offer. And so you can see there are smaller panels that are limited to a smaller number of genes. There's very broad-based panels. There's a lot of overlap through the middle of that chart. And again, this is kind of what we use to help guide our management. We are routinely offering patients panel testing, but we really have a discussion with them as to how much information they want and try to identify what is the most pertinent and important genes to be included in their evaluation based on what their personal and family medical history may be. So the strengths of multi-gene testing is that certainly it is the most efficient way to evaluate, both cost-wise and time-wise, and really kind of, instead of looking at a family history to say, well, it seems like maybe this one gene is the most important factor contributing to cancer in a family, rather we now more often will look and say, you know what, it looks like there may be something genetic. Why don't we test for a number of different things and see whether something comes up or not? And so it allows for more expansive testing. With these more moderately penetrant genes, we don't see as many cancers in the family. And so these families are sometimes difficult to identify. You know, the question being is, do we need to identify who these families are? But I think that some would argue to say, even in the presence of a moderately penetrant gene and a moderate cancer risk, there are still guidelines that we would alter medical management. And so for some, this is worth knowing about. And finally, again, this genetic testing allows us to identify a potential hereditary risk that then could translate to others in the family being able to pursue single gene testing themselves. There are certainly limitations to panel testing. Like I said, there are genes, lots of genes that we can test for. We do not understand all of them to the same degree. And so with panel testing, there is always the potential that we are testing for things that are not fully understood. There may not be well-defined cancer risks or medical management options to offer to a family in the presence of a mutation in some of the newer genes. And for some people, this is more information than they wish to have. You know, if we don't really know what to do with the information, some patients would prefer not to know about it. There also is increased risks or rates for there to be variants of unknown significance when we are testing newer genes that are not as well researched either. And so these are all things that have to be given consideration when pursuing genetic testing or when facilitating genetic testing for a patient. One of, I think, the most important pieces is that anyone who is facilitating genetic testing is the need to understand how to interpret the test results. And this can be somewhat challenging because despite what people would assume, genetic testing is not always black and white, yes or no. There's actually 5 different results that we can receive for every gene that is evaluated. And I think that, the obvious being positive or negative, in the sense that if we identify a mutation that is known to affect the function of the gene, it's associating with a risk for cancer, these are the results that are going to impact medical management. These are the results that are going to translate to genetic testing being offered to other family members. The negative result is kind of on the other end of things, but I think the one that often is not given much consideration is the one that falls in the middle of the road. And this is kind of the maybe result, which is what they term a variant of uncertain significance, which identifies that there is a variation within the gene, but at the moment there is not enough information to fully interpret the significance of that variant. Is it affecting the function of the gene? Is it associated with a risk for cancer? Or is it potentially very benign and the gene functions just the same despite that change, in which case we would not be modifying those family members' medical management. And so I think the most important thing for providers to understand is that when they come across a patient who's had genetic testing, they have a variant of unknown significance, this information should not be used to influence medical management decision making. Variants of unknown significance are being actively researched by the testing laboratories, and eventually more detailed information will be provided on the significance of that finding. But what we do know is that the majority of these variants ultimately end up being reclassified as nothing. And so in that case, we certainly do not want to see patients pursuing procedures that they may not need and that have risk associated with them. The other parts that come up with doing result interpretation is that we need to understand that a negative does not always mean a true negative. We do genetic testing for somebody who's had a diagnosis of cancer or somebody who's had a family history of cancer and the testing comes back negative. We didn't find anything. Well, that doesn't mean they're not at risk. It just means we've ruled out to the best of the current technology the genes that we've been evaluating for. And so we always have to return back to the family history and say, well, there may still be a risk, and maybe there's a genetic factor we don't know how to test for yet. And in that case, the medical management and the screening still needs to be considered potentially at a higher risk and at a higher level for that patient. We also need to understand that variants of unknown significance are going to be reclassified eventually. And so some providers would say, well, we don't need to tell the patients about it, we don't understand it, and most likely it's not going to be of significance. But sometimes they are reclassified of being of significance, and now somebody's going to have to reach out to that patient to say, that testing you had a long time ago that we said was negative, well, it's actually not negative. It's a lot easier to have that conversation if the patient was informed at the time of the testing that there was something found, despite the fact that it was not fully understood. And it is the ordering provider's responsibility to notify patients when there is a reclassification for these variants. And so providers need to have a system in place and be prepared for that when it comes. And then one of the biggest things that comes with genetic testing is trying to help facilitate what we call cascade testing, which is that when a patient is identified to have a mutation, is trying to help empower them to share this information with their family and engage their family members to pursue genetic testing themselves to better identify what risks they may have. I think one of the biggest things that comes up is as genetic testing has now been around for almost 20 years as it relates to hereditary cancer risk, is that we need to always be reevaluating. So whether this is patients who had genetic testing done in the past that was positive, there was a mutation found identifying risk, we need to realize and understand that our understanding of what these mutations and these genes contribute or are associated with is going to change over time. And so we need to make sure that as new cancer risks are found to be linked to certain gene mutations, that these patients are being advised of this and that their medical management is being adjusted appropriately. We need to understand that patients who had genetic testing in the past that was negative, they are likely candidates for more gene testing. There are more genes than ever before that patients can be tested for, and for many people who were tested prior to 2015, it's very possible that there is additional genetic testing that they would qualify for and that they may wish to pursue, and we need to be advising of them of this and giving them that option. And we also need to realize there may be patients who were evaluated for whether they were candidates for genetic testing in the past, and they were told no, they were not. But now maybe they are, and maybe that's because their family history has changed. There's been new diagnoses that have come up since the last time this was evaluated. But it also may be that the genetic testing criteria has changed as well. So a few quick examples of kind of family histories that we have worked with where genetic testing unfortunately was not introduced in the most timely fashion and how it kind of impacted. So we worked with a 58-year-old female who had a history of early onset bilateral breast cancer. She really did not have a significant family history of cancer, and she had had BRCA testing done back in 2009 that was negative. And so what you're looking at here, this is a pedigree. This is kind of the base Bible of what we do in genetics and looking at a family history. And so what you're looking at here, the circles are the women, the squares are the men. And so if you look here, the arrow is always going to indicate to you who our patient is. And so this is her patient, her brother, and her mom and her dad. And so this is just to show you, again, it's a rather small family. And there's not a lot of diagnoses, but she did have early onset breast cancer, and that certainly is concerning to us from a genetics perspective. Unfortunately, what ended up happening is that years later, after she had had her testing, she eventually was diagnosed with an ovarian cancer. And when that came up, what she ended up doing was being referred back to genetics finally at that point. And what we found was she actually did have a BRCA mutation. And so what this shows is that, because she was not given follow-up genetic evaluation, she ended up with an ovarian cancer diagnosis. And I think what could have been done is that potentially had that genetic testing happened sooner, we would have identified her risk for ovarian cancer, and she potentially could have pursued preventive surgery and maybe avoided that diagnosis. And so we have to always be keeping in mind that genetic testing is not a once-in-a-lifetime thing. The technologies are going to change for the individual genes. The genetic testing sensitivity is going to improve over time, and other genes are going to be coming into the consideration as well. We always want to say, don't forget the men. So much focus of genetic testing is related to breast and ovarian cancer and these BRCA1 and BRCA2 genes, but the men are part of this as well. And so we had a family situation where we had a man who had had prostate cancer. He had, in his clinic notes through urology clinic, been found to have family members with prostate cancer as well. Eventually he made it to genetics, and what we found is when we took a more full family history, he has quite an extensive family history of cancer. And so what you can look at here and see is that beyond his diagnosis, he had a brother with prostate, his dad had prostate, there was a paternal aunt with breast cancer, there were several cousins who had 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 prostate and pancreatic cancers. Unfortunately, what finally got the genetic ball rolling, though, was that his daughter was diagnosed with early onset breast cancer. And upon genetic testing, we found that there was a BRCA mutation present in her. And then backtracking through cascade testing, we did confirm that mutation was present in her father and likely was contributory to his prostate cancer. And so again, what this serves is that unfortunately his daughter was not having early onset breast cancer screening because there was not yet an identified risk for cancer in her or her family. And had genetic testing been done in a more timely fashion for this gentleman, potentially his daughter would have been being screened differently, and it could have had an impact on her diagnosis and outcome. So the next case example we have is a 25-year-old female who had been diagnosed with a desmoid tumor. Outside of that, she had no other real significant medical history to speak of, and therefore would not necessarily have caught anyone's attention as needing a referral for genetics. However, there is an NCCN guideline that would suggest that any individual with a desmoid tumor should be given consideration for genetic testing related to a potential diagnosis of FAP, or familial adenomatous polyposis. And so eventually this patient, by the urgence of her family members, found her way to genetic testing. When we met with her and collected a full family history, as you can see, there really is nothing to speak of in terms of any cancer diagnoses in the family, and it is a rather large family. However, based on her personal history of a desmoid tumor, genetic testing was completed, and she was in fact identified to have a mutation in the APC gene related to having a diagnosis of FAP. And so, the impact of this is that based on that, she then followed through to have a colonoscopy completed. She was found to have extensive polyposis and subsequently underwent prophylactic colectomy. And so I think the big change here had been, had she not had genetic testing, she would not have had a colonoscopy, certainly at her current age in her 20s, and therefore would not have really come to realization until she became symptomatic and potentially had a colon cancer diagnosis. The next case is a 43-year-old female who had a very significant personal history of cancer. This included a personal history of early onset breast cancer, followed by a diagnosis of a leiomyosarcoma. She then most recently had been diagnosed with colon cancer, and through all of these various diagnoses, in fact, had never been referred for genetic testing. And interestingly, without having 3 primary cancers, even her first diagnosis of early onset breast cancer certainly qualified her as a candidate for genetic testing. She again comes from a family that is rather unremarkable in the sense that there are numerous people in the family. There are very few diagnoses that have ever been documented of cancer in the family. But again, based on her personal history, genetic testing was warranted, and upon completion of such, she was found to have a mutation in the TP53 gene, which did confirm a diagnosis of Lee-Fermini syndrome. Lee-Fermini syndrome is another condition where we can see a very high new mutation rate, in the sense that it's not unusual to find that somebody may have this mutation and not have a significant family history of cancer, as the mutation is more focused just to her. And again, the value of having identified this would be to indicate that she certainly has a risk for other primary diagnoses moving forward, and now her medical management can be tailored accordingly, as well as the fact that she does have 2 sons who each have a 50-50 chance of having inherited this mutation, and now they can pursue genetic testing and potentially medical management can be set up appropriately based on what their risk may be. This is a case, so this is a very different one. So this is a patient who actually had genetic testing. However, there was misinterpretation of what her test result meant. And so she was a 65-year-old female who had been diagnosed with colon cancer. Tumor tissue evaluation was done showing microsatellite instability. There was also absent protein expression related to PMS2. All of this was suggestive of a potential diagnosis of Lynch syndrome. And so genetic testing was completed, and she was identified within the PMS2 gene to have a variant of unknown significance. And so, again, this is another situation where large family, not a lot of cancer diagnoses, certainly not highly suggestive of Lynch syndrome. But we do know that mutations in the PMS2 gene tend to present a milder form of Lynch syndrome. And so, certainly question was, well, was this variant within the PMS2 gene actually pathogenic? Was it problematic? But as it was classified as a variant, the recommendation would be that her medical management should not be based on such. Unfortunately, what eventually happened is that this female followed up and was being followed as if she had Lynch syndrome in terms of her screening and medical care, and subsequently ended up pursuing prophylactic hysterectomy related to a concern for a risk for uterine cancer, which all predicated on the idea that she had Lynch syndrome. In fact, she does not. And so again, it's very important that these genetic test results, that not only is genetic testing being done when appropriate, but that the test results are being interpreted appropriately. And so I think the big message here is to say that genetic testing is certainly very important. It's going to have a huge impact. However, it's going to have an impact on a very small proportion of cancer patients, since the majority of cancer is sporadic. But the impact to the extent of their family is going to be pretty massive. This can have an impact for immediate treatment planning. It could have impact on long-term screening and medical management. It's potentially going to help patients make decisions, and it's going to help their family members as well. And I think that as providers, we need to be aware of identifying patients who are appropriate for hereditary cancer susceptibility evaluation and testing. It's a liability if we're not. And certainly here at Roswell, as being an NCCN institute, and there are NCCN guidelines for genetic evaluation, we need to be paying attention to these and trying to identify patients when they are appropriate to be providing the top level of care that the patients need to be receiving here. And so kind of take a different direction here. So I want to talk about a couple other areas where cancer genetics and genetic testing is being applied and used in the clinical setting. Obviously, tumor tissue testing has taken off here in the last few years as becoming quite mainstream in being able to identify tailored treatment-related decisions in a medical oncology setting. And as this is becoming more and more part of the treatment plan for patients, what we're finding is a lot of patients don't understand the difference between tumor tissue testing versus hereditary cancer testing. And so as providers who may be interfacing with these patients, I think it's really important to try to clarify for them the difference between the two, and for providers to really understand that patients are not understanding the difference. As a provider who may be facilitating tumor tissue testing, I think in general they need to provide the patients with a little information ahead of time, which is to say it's not unusual for there to be numerous mutations identified within a tumor. This is what cancer is. That they need to understand that the mutations that are found in a tumor are not necessarily heritable, that it's not something that could be passed on to their relatives. But they also need to understand that in doing this tumor tissue testing, they may have hereditary risk identified. There are patients who do not want to know this information, and so they need to know that possibility that those results could lead us down that pathway if they are consenting to having tumor tissue testing completed. I think it's really important that in a provider facilitating tumor tissue testing, they need to have a plan for the next step, which is to say if there are mutations identified in a hereditary cancer susceptibility gene. So of all the genes that are being tested within these tumor tissue tests, the majority of them have no significance to us in the world of inherited cancer risk. But for the 40 or so genes that may, it's important that providers are kind of mindful of those and are aware of those. They need to understand that the allele frequency should not be used to guide whether germline testing should be subsequently pursued. That more significantly would be to look at the personal and family history. If there is a mutation found in the BRCA gene on somebody's tumor tissue, do they have a personal or family history of breast or ovarian or pancreatic cancers that would be suggestive of this? The other thing we have to realize is that the testing laboratories that are performing somatic tumor tissue testing versus germline testing, they have different variant classification systems, they have different nomenclature, and so we can't always compare results across one platform of testing to the other and rely on them being equal or comparable. And so a lot of times if something comes up on the tumor tissue result, it may be very appropriate that there be confirmatory germline testing offered to the patient and that being facilitated within the genetic clinic. And so what we know is that if there is a somatic mutation in a BRCA gene, this is certainly very suggestive of there being a germline mutation. It doesn't always equate to such, but again, we relate back to what the family history is. There is a guideline in NCCN that says that there should be confirmatory testing offered anytime a BRCA somatic mutation is found. There are other genes that we would give equal consideration to. PALB2, the Lynch syndrome associated genes, these are all genes that when there are somatic mutations identified, a good proportion of them may equate to it actually being a germline mutation, which would be important to that patient and their family in identifying future cancer risk. On the other hand, there are a lot of genes and a lot of mutations that are very common to the tumor and don't necessarily raise a high concern on the inherited side of things. And so, this may be certainly mutations in the TP53 gene, the APC gene, the P10 gene. We see these on a lot of tumor profiles. And for a lot of them, they do not equate to there being an inherited risk in that family. Anytime you are thinking about an APC mutation, we know that generally that's going to equate to a significant presence or phenotype of polyposis. And so if we have a patient or a family where there's really been no polyposis or colon cancer, we have a very low threshold of concern that this APC mutation is hereditary. In the follow-up, so if a patient has had tumor tissue testing performed, We need to think about if the testing is negative. There were not any significant mutations identified on the tumor tissue that would suggest a hereditary risk. That is also not the end point of genetic evaluation. There are a lot of reasons why the tumor tissue may come back normal, but there actually may be an inherited mutation present. And so, it certainly can be that some genes are not tested for. Some of the genes that we do need to be considering from an inherited standpoint may not be part of the test platform for the tumor tissue evaluation. The technologies are different, and so like I said, we definitely know that within the somatic testing there are certain types of mutations that are often not being easily identified or reported out that are significant from an inherited standpoint. And we know that with tumorigenesis, there can be mutations that revert, where there certainly was an inherited mutation, but within the tumor it is not present any longer. So again, a patient who still meets NCCN criteria for hereditary cancer testing should be offered such, even in the presence of a negative or normal tumor tissue result. Separately, one other topic that is becoming increasingly important to have some awareness of is something called DNA banking. And so DNA banking is simply offering the patient the ability to have a blood sample collected and stored for future use. And so this is something that is routinely being offered in a couple scenarios. So if we have a patient where there's a significant history of cancer, we've done genetic testing, we didn't find an explanation for the cancers in the family, DNA banking is a good way for them to kind of set aside a sample so that as new genes are discovered in the future, that testing could be pursued at that point, even in the absence of that individual being available. This is also something that is very useful for families that are facing a terminal diagnosis. And so sometimes genetics is not brought up until the very end stage. And so rather than kind of dragging that family through the genetic counseling and genetic testing process, DNA banking would allow them to simply obtain a sample from the affected family member who is the best patient to have the testing performed, and otherwise just set it aside, spend time with their relative, and then we can come back to this down the road. And so DNA banking is something that a family can pursue without necessarily interfacing with the clinical genetics service. This can be performed by hospice if necessary. It can be facilitated within the home clinic. There are multiple labs that offer this service. And the one thing that we always have to make sure patients are aware is that this is an out-of-pocket expense. So DNA banking is not routinely covered by health insurance companies. But generally, the cost to the family is under $200. It's a one-time fee, and that sample is stored and it is owned by the family. So it's not contributing to research. It is something that is there for their discretion and for their use in the future. So I think the key takeaways, the most important pieces that we would want people to understand about genetic counseling and the genetic testing process in relation to cancer risk is to know that pre-test counseling is important. It's important that patients are aware of what they are consenting to, what the testing may tell them, what it may not tell them, how much information they may want. We have to obtain informed consent. New York state law requires written informed consent for genetic testing to be completed. And that any ordering providers who are facilitating genetic testing need to be comfortable with what the possible results may be and be prepared to counsel the patient on this, or certainly be prepared to refer the patient to a genetics provider for that process. We talked about the possible test results. Negative is not always negative. It's important that patients and providers understand that the majority of patients who are completing genetic testing at this time do not have a mutation identified. And I always say we only test patients we expect to find something in, and yet 80% of them, their test comes back negative. And so certainly for a proportion of them, there may not be anything genetic to be found, but for some of them, there certainly is an increased risk that is still there. And so they need to make sure that they understand that. A negative result is not a get out of jail free card. They still need to be screened and followed as if they are at higher risk. And as we talked about, variants of uncertain significance need to not be overinterpreted. A patient should not look and say, well, there was a finding in the gene, therefore we need to treat me as if I have significant risk, which in cases is likely not the situation. And the final piece is, you know, certainly we need to always be revisiting the family history. We need to be revisiting what genetic testing was done in the past and what's available today. Patients who've already had testing, there's often more that may be available down the road. We encourage every patient that we've met with to stay in touch with us so that we can always be revisiting whether there is additional testing to offer them in the future. But we really encourage the providers who have an ongoing relationship with the patients to be revisiting this as well. There's certainly a big change in the paradigm and the delivery model of genetic testing and genetic counseling at this point. Ideally, all patients should be offered formal genetic counseling prior to proceeding with genetic testing, but that certainly is not realistic. There's not enough of us for the number of patients that need testing. Testing needs to be done in a more timely fashion nowadays as these results are impacting therapeutic decision making. So there needs to be a shift in how this is being done. And so new delivery models are being developed to kind of look at how can we collaborate with other providers in the healthcare system to try to ensure that patients are getting genetic testing in a timely fashion, but yet making sure they're getting the right information, they're getting the right testing done. And so here at Roswell, we are exploring a point of service model to kind of look and say, okay, can the providers, when they identify a patient who's appropriate for genetic testing, rather than refer them to the clinical genetic service for another appointment, can we help them to facilitate the genetic testing while the patient's in their home clinic? And so for right now, this has been explored within the GYN clinic related to ovarian cancer patients. All patients who have ovarian cancer, regardless of their age of diagnosis or their family history, are candidates for genetic testing. So it's kind of a very straightforward situation. And so we have worked with the GYN clinic to create a process for this. We in the genetic service created a video, an education video for the patients to watch. So when a patient is identified as a candidate for genetic testing within their GYN clinic appointment, they are given the video to watch. 10-minute video. It gives them the bare bones of here's what genetic testing is, here's what it could tell us. And then the patient's given the option. Is genetic testing something you're interested in? Do you feel like you have more questions and you need more information that you would like to meet with a genetic counselor prior to moving ahead with the testing? And so they're always given the option to meet with us before doing anything. But if the patient wishes to proceed, they are then given the opportunity to do such at that clinic visit. The informed consent is completed, blood is drawn, test is ordered. And then the plan is set up that when those test results come back, any patient who is tested positive or found to have a variant is referred to us in the clinical genetics service so that we can be involved in that result interpretation and making sure that the patient and their family understand what the result means and what the significance of it is. And so this is something that we're going to explore rolling out into other clinics as a way to try to move the process along and not have patients being held up getting to their genetic testing information. And at the same time, there's always going to be more complex cases that are going to still need to be referred to genetics. And so it's kind of trying to find that balance. And so I think here at Roswell, in terms of what we are doing, the clinical genetics service, any patients that need to be seen can be referred to us through the EHR. There are 3 options when placing that referral to identify the timeliness for the consult. And so we would say, majority of patients probably are routine in the sense that a test result's not needed immediately for treatment planning. However, they can be identified as being time sensitive or being an urgent consult. The time sensitives often are ones who may be getting neoadjuvant chemotherapy. They're going to have surgery coming down the road, so we want a result in a certain time frame, but we don't necessarily need it within the next couple weeks. And on the other hand, the urgent referrals are patients where immediate surgery may be pending, and so we really need to get genetics moving. Genetic test results often are taking still about 3 weeks to come back, and so we need to kind of build in that time frame to say, okay, if the patient needs to be seen and we need a test result within the next month, let's make sure we get them in here in the next week to get the testing process started. And so as providers make referrals, if they give us the timeline, certainly we are going to help to make sure that the testing's done in the appropriate time frame. When patients are scheduled to meet with us in the clinical genetics service, there's actually 3 different appointment types that they may receive. They may have a routine appointment where they're going to meet in that kind of 60 to 90 minute time frame for a full formal counseling At the same time, we've also started what we call a fast track appointment, and this is generally reserved for the most straightforward patients and family histories, where we are sending them that video to watch ahead of time, the patient education video. And when they come in, their appointment is a 30-minute appointment where it's very much the bare bones of, hey, you meet criteria for genetic testing based on the family history information you've provided. Is this something you want to pursue? Do you have any questions? And let's just get it moving forward. And then we'll talk in more detail once the test results come back. And so fast track appointments have allowed us to get people in a little quicker as well. And then we also perform group consults here, which is taking numerous patients, anywhere between 6 and 9 patients who have a very similar personal and family history. They're asking the same questions, and we bring them on all at the same time, where we will do a presentation to them to give them the very general genetic information that we share with anyone. And then they get to meet one-on-one with a genetic counselor for about 10 to 15 minutes to address personal and family history information and make a personalized or individualized treatment plan. And so we have a lot of different ways that we're trying to manage the patient volume, but certainly we always say if there are questions, all people need to do is reach out and ask us. So whether that's that we need somebody to be seen quicker, whether it's that we need somebody's appointment moved up, or whether it's simply, hey, I have this patient and I don't know whether they need to be seen, period. We would really encourage people to please feel free to email us, call us, text us, page us, or worst case scenario, put the referral in and we'll put eyes on it. And if it seems like it's not appropriate, we'll communicate that back to you. So this is our team here at Roswell. We do not have a home clinic, so we are found in various places on different days, but you can always email or call us or our clinic liaison to touch base, and we are here to help as we can. So thank you very much.